Yeah, we haven't really officially started, have we? I mean, if we have, great.
It's
Can the
5:02.
can the can the attendees hear us?
They may or may not have heard the whole thing.
Are we broadcasting, Michael?
We are broadcasting, yes.
Well, how about that then? Welcome everybody. Well, I think without further ado, welcome to the party.
A row, a ruction, a fracas and a fray, a rough and tumble free for all, a broiler brawl Malay. A ruckus to be reckoned with if anyone wants to dare. We're taking the road to the Don or down to the Donnybrook Affair. I will go, I will meet you there. I will spend a week or two.
We're casual here. Hey, I'm Ben, and we got a great group together here. This is C3RO, and this is case number 2. You're gonna see, if you watch the video from our first case, you'll see that we've made a couple tweaks and improvements. And first thing I want out of the gate is to say, give us good ideas on tweaks and improvements as we go along. We want to somehow have some regularity and a pattern, but we want to constantly be making it more useful for you. And who are you? You are the people who are watching this, not just the people who participated in the contouring. I think we have somewhere between a 5 and a 10x participation level for people who just want to consume the output rather than those who are actually contributing contours. And that's good. You're all welcome here. We will start off. I think I'll share my screen. While I'm sharing my screen, maybe Michael, you can do a little bit of the rules and regulations and that kind of thing.
Absolutely. Let me know if you have any difficulty sharing. So in the meantime, hello everyone, and welcome to our second live results discussion. We're thrilled to have you all here. Just a couple quick housekeeping items before we get started. For our live attendees. So first, all attendees are muted with the webcam off, so no need to adjust your webcam or microphone settings. Second, if you wish to participate in this discussion, there is a Q&A function down below, as well as a chat box. So feel free to ask any questions and help guide discussion. And third, if you have any questions afterwards, please send an email to support@econtour.org. We are always looking for some suggestions. And finally, in the interest of keeping this collaboration informal and collegial, we will be addressing everyone by first name. Now we can get underway.
Very good. And a disclaimer that as long as I remember to give it, I'll give it every time. I promise you I will screw up. And we're figuring this out as we go along, and we're having a good time as we do it. So don't expect polish, don't expect perfection. Do expect interest and to learn something. So without further ado, I just have a few slides, and start off with the most, we got that. We'll start off with the most important one. We have 2 featured panelists today. We'll just go from left to right. Well, Matt, let you introduce yourself, and then followed by Shauna.
Yeah, thanks for having me. I'm Matt Spraker. I'm an assistant professor of radiation oncology at Washington University in St. Louis, and I'm the chief of our sarcoma service here.
And hi, everyone. My name is Shauna Campbell. I'm one of the radiation oncologists here at Cleveland Clinic. I did my residency here, finished last year. So I'm very grateful to be here, and thank you for the invitation. I treat sarcoma as well as head and neck here.
Thank you. Thank you both for being here and for offering your expert contours and opinions and willing to go out on a limb. Matt, I will say I'm born and raised in Missouri originally, so this is the season to say go Blues, I guess. Just a couple methods first to get you guided on how we're going to do this. How do we collect data? How do we analyze variation? So I'm going to show these slides for just the first few podcasts, and then we'll be done with it. This is just a head neck example. What we do is we open it up to use the cloud-based Prono platform to get people to blindly collect data. Here we have a left thigh sarcoma, and we had 4 critical structures. That's one of the changes we made, by the way, from first session versus second. We wanted more discussion, more drill down, in-depth discussion. So we reduced the number of structures to 4. So we should have plenty of time to discuss each one today. But we throw it out there to the participants. I think if you ask Matt and Diana, we're probably up to close to 1,000 people who've signed up to be eligible to participate. This was a unique case, so we got our duty cycle was a little low, but we did get 65 people to submit contours. Currently, the pool of people who can submit contours is all physicians, radiation oncologists, not opened yet to dosimetry or physics. We collect those data blindly and we do population analytics. So we take these spaghetti lines and we make them into 3D things that look like dose clouds, but really it's ISO agreement lines. This is a way to help visualize and quantify variation. From that, we get to analyze some metrics from that. So we're going to go through one by one, structure by structure, and look at the clouds of agreement. We're going to look at histograms of absolute volumes. So these would be just a very coarse macro metric on what did people think just contour in terms of volume, not necessarily where, but how much. But then we do something pretty cool, and it's a way to really put a metric on variation. We put two of them forth. One is what's the volume where there was 25% consensus divided by the volume where there was 75% consensus. As you get higher and higher in consensus, the volume mathematically gets lower or stays the same. So you'll see that these metrics will asymptotically approach 1, where 1 would happen if everyone agreed to the very pixel value. So 1 is never going to be achieved, but 1 is perfect consensus, and the larger it gets, gives you an idea of the volume ratio. Think of it like a gradient index, like you do for SRS and SBRT treatments. And then new this month, what I tried to do, and we'll be getting better at this, is it's also good to do a sensitivity analysis where you say, all right, if there was this degree of contour variation, what might the implication be to a DBH, the type of thing that you assess and approve a plan by? So I was able to do something like this, and so this will be the first month where we're looking at something like that. We're about to get started, so we're going to play this game every time. To our two panelists today, we had GTV, CTV, genitalia, and the skin strip, which was an optional structure. So I want you to kind of make a prediction before we see the results. Which structure do you think had the most inter-observer variation, and which had the least? Jump on in there with your opinions.
I'll let Shauna go first.
I'm gonna go with the skin strip.
As the most variation?
Yeah, as the most variation.
Okay.
I was going to say the same thing actually as well. Yeah.
But
Excellent.
I do think there's a lot of room for variability in how you would contour genitalia.
I tell you what, let's be more, since we have two panelists and only 4 structures, let's take it up a notch. Order them, predict the order from most variable to least.
Most variable to least. So I would
skin
say
strip.
skin strip, genitalia, CTV, then GTV.
I would have the same thing, except I'd actually have CTV and genitalia flipped. I think that there'll be more variation in CTV than in genitalia, but we will see, I guess.
You both passed the test. One of you passed with a perfect score, and that's Shauna. So the most variable was the skin, and we'll put some numbers on this in a second. Most variable far and away was the skin strip. Then next most variable was genitalia, and I think you might be surprised at the degree of variation in that. The CTV did show a high variation, so Matt, you weren't too far off the mark there. We have our first ever very consistent structure though, and that's the GTV. So that might be aided by the fact that we had a PET fused on this one. We get to, let me show you the numbers, and then I'm going to let the two panelists pick what order we want to basically go through the results in. But here are the consensus gradient 2575 and 1090. So the skin strip being infinite means that there were no voxels anywhere that everyone agreed on. In fact, there were no voxels anywhere that 75% of the people agreed on. The denominator was 0. So now we get to the genitalia, and you see 75% agreement. 25 divided by, I think, yeah, I might have this ratio. It's the 25-75 ratio. It's 2.8. So one of the volumes was almost 3 times as large. And then 16 times as large when you start looking at the 10th and 90th percentile. Got a little less variation with the CTV. And then the GTV really qualitatively how we can think about this 1.96 is that where there was 90% agreement, where there was 10% agreement, so at the fringes of being the union of everything, divided by the 90% agreement, so it's at the fringes where everyone agreed on it, it was just a factor of 2 in volume. And where you're at 25 to 75, it's only 1.26. It's definitely very low. So pick an order and we'll start plowing through one by one. Shauna, you got to guess first, so Matt will let you pick the order of operations.
Well, let's start easy then and look at the GTV since there's most consensus with that, maybe.
Let's do it. All right. First, what we're going to do is we'll look at that cloud that I told you about. So this was n equals 64. Actually, I have this wrong. This is n equals 65. I was able to run another analysis, but so I'm going to turn on that cloud, and it looks like a dose cloud. Let me make it so that we see every 10 percentile. And this is a nice steep gradient.
Mm-hmm.
You don't see these very much. So that's a really good news in terms of where people were finding the GTV. So you can, I tell you what, while we're doing this one, let's also turn both of your opinions on. I don't know which of you were panelists 1 and 2, but you can see we have 2 red lines and they're pretty close. So I might just start at the top and kind of work our way down, and then you can backseat drive and tell me where to go.
One thing I wonder if you can do is if you turn off the dose cloud first, or the, what are we calling it? The contour, what do you call that?
ISO agreement line.
ISO agreement cloud. And then maybe just flip back and forth quickly between the MRI and the CT, because I wonder if there's a little bit of size difference between, oh, there is, yeah. So actually that might explain some of the variation. I don't know if that explains the variation in ours actually look almost identical, right? They look very similar.
The 2 of you were very like-minded. There was a little bit of a bulge here.
Mm-hmm.
for again, I don't know who's who, but you might be able to notice on there. But look at, this is the sagittal reconstruction, the coronal, axial, pretty much right on top of each other, except for a few regions.
Yeah, and I generally like I'll use all of the imaging for creation of a target or a GTV for sarcoma, and it's not uncommon at all that that there can be a little bit difference between them because the images are grabbed at separate times. And in our case, like at our center, we have a lot of people that come from pretty far away. So they might get an MRI and then a CT. And there was a time, they'd get the MRI kind of on the outside. We pull that in as part of our kind of pre-patient, consult sort of information gathering. And then we'll do the CT simulation and use that. So whenever I have imaging, I typically will use like the worst scenario. Like I'll use like the biggest tumor on all of the imaging to kind of create the GTV. And typically that's the CT sim because it's the biggest one. We're sort of lucky in this case that you can actually see it really well with a CT scan. It's not always the case with sarcomas. So I thought that, that probably explains maybe some of the variation if people did it with the MRI versus the CT.
Yeah, and I apologize earlier. I think I said PET. This is clearly MR, so. Shauna, what are your thoughts?
No, I wish all of my sarcomas looked like this. But no, I agree with Matt. I think that's probably his, which is Poochie, to catch that flare a little bit more than mine on that slice there. So I think I probably cheated that corner just a little bit based on, again, flipping between the 2. I saw sort of the greater representation was on the CT images, but it shows the importance of how you can, just that little bit of edema signal there is definitely present. So I agree with that.
Are you able to get MR? Are you able to get multimodality for all of your sarcomas, or is this a luxury?
So I can, yeah. So everyone should have an MR at least at some point. It's kind of, it's pretty unusual to not have one. It mostly comes up in patients that can't have an MR for whatever reason, pacemaker or something like that, because a soft tissue mass, it's still from a radiologist perspective, an MRI is the best scan for that problem. So prior to knowing that it's a sarcoma, most patients will get an MRI at some point to investigate kind of like a new soft tissue mass. We actually, I was going to bring up, it's an interesting point. Some people will do an MR at the time of SIM, and I don't know if Shauna, if you guys do that. I tried that kind of when I started. It is a heavy lift for the patient because you're getting like another MRI, and if anyone's had an MRI, they're not super comfortable, and some patients are claustrophobic, and it might be hard for them to do. But during COVID, we are a little bit limited in our department in terms of like quote extra procedures. So if someone comes in and they have an MRI and you can just fuse it, at least in the last year and a half or so, we've kind of been not really doing those just because it's like an extra procedure and another couple hours in the department if they're going to stick around and do the MRI in the treatment position. There's no question that it's a luxury to have a treatment position MRI because I don't do my own fusions. We have a staff that does that, and they frequently write me apologetic emails about how they tried their best to fuse. These people are almost never in the same position, or you'll see like in ours, there's actually some, if you go back and forth, there's some deformation of the limb itself. Like that gives people a lot of challenge. My group does a fantastic job, so it's really a kudos to them, but it's something that if you have a harder time with fusions or more, if it's more of a burden to do them, it might be an advantage to do a treatment position MRI.
Yeah, that was one of the things we noticed with this data set is it was fused based off the location of the tumor, but clearly the patient is not aligned because so this was a diagnostic MR. So these registrations are challenging to do because they do end up, informing the contouring quite a bit.
Yeah, I think on this case, it was nice because you have a fairly well, circumscribed lesion, which makes the fusion that's not in treatment position a little bit easier. At my institution, we do get an MR in treatment planning position very routinely. It's nice if the old MR is a little bit dated, but even if it's not, just the deformity that you can get, I give your team big kudos, Matt, on getting those fusions in. They are so frustrating to do. Those are the one fusions I'm always asking physics. I can't get anything fused properly. I had one of the brachial plexus the other day and I couldn't get anything to line up. But so we as routinely do often get an MR in treatment planning position.
Excellent. I forgot earlier to introduce another co-founder of C3RO and radiation oncologist, and our moderator for this session is Dr. Erin Gillespie. So Erin, you butt in whenever you want. Don't let me talk too much.
Yeah, no problem. I was just going to ask, how do you guys pick which sequence of your MRI to look at and fuse and try to figure out where the edema or not is?
Yeah, I don't want to talk too much, but I guess, yeah. So generally it's pretty standard to do a T1 with contrast and then some kind of T2 weighted image, which is incredibly variable across institutions. And you even sometimes use T2 fairly loosely where you're actually using like a proton kind of weighted image as opposed to a true T2. So those are ones where I see those pretty variable across institution. Sometimes they'll do a stir image as well. And the primary role of the T2 is really to capture edema that may be outside the gross tumor volume that you otherwise would not capture in your CTV. So to be clear, we'll talk about the CTV in a minute, I guess, but to be clear, it's actually edema that spreads beyond the extent of the CTV. And I would just say on my experience, it's very unusual for that to contribute to changing the volumes. I actually have not seen very many patients where you're chasing edema beyond the normal treatment volumes that you would deliver. I don't know if Shauna, if you feel differently there. Or...
No, I agree with that. Again, just the T1 post and then, your T2 or some kind is often all you need. You don't need a lot of sequences. When we do our MR treatment planning, it's not like a full diagnostic MR with, all the different sequences. It's often an abbreviated. It includes T1, pre, post, T2.
Excellent. So I did another interesting thing. So we're trying this out. I think it'll be useful. One thing is, if we go back and revisit the consensus of the population here, again, it was n equals 64 or 65. You see, just it's really nice. So the population here is agreeing with our panelists. Got the little bit this, this one little difference here is the only thing you might notice. Well, in terms of doing a sensitivity analysis, what I was able to take was, and this might have been a plan from WashU, I'm not sure, Matt, you could correct me, but we took an example VMAT plan. Now, doing a DVH sensitivity analysis when you're looking at contouring variation is difficult. The ideal way to do it is to have everyone who drew their contours also generate a highly conformal plan, and then to take a gold standard structure set and overlay it on each of those to get what you thought the DVH would be versus what it might really be based off a gold standard. Well, we're not dealing with gold standards here, and we certainly don't want to ask all of our participants yet to do treatment plans, maybe in future sessions. But what I was able to take was an example VMAT treatment plan based on example contours and overlay that dose on everyone's opinion of a contour. So the way you might think about this is, let's say the plan was created based off obviously one set of contours. Given everyone else's blind opinion of what the structures were, what would their DVH have looked like if the patient had been treated the way that someone else contoured, if that makes sense. So what I did in order to achieve that is on every participant, in fact, those of you who contoured, you may log in and go, you can't change your contours, but you may see that there has been a dose added to your patient. It's not your treatment plan, it's not your dose, it's this plan here. And this is just a dose grid that I overlaid on top of everyone's, and I was able to then get DVH variation. I do this via what we have in Prono called collection analysis. So if I go to case 2, we have something called the population DVH, and I've generated one. So this will become more and more spread out as you see the DVHs are different. Now, given that the GTV was small and inside of this dose, you see here, this is about as pristine a population DVH as you will ever see. There are 65 different DVHs here broken up into 4 quadrants. You can hardly tell the difference from 0% to 25 percentile, the median to 75 to max. They're basically on top of each other, which means this particular the GTV fit nicely inside of the prescription dose. Now, this will not be the case for other structures, obviously, but this is a good baseline. Like in an ideal world, this is what our population DVHs would look like if everyone was doing consistent, perfect work. We will move on.
Since people are usually putting their, auto expansion on your GTV to your CTV, why don't you show us what those look like?
We'll see that when we do the CTV.
I know. Are we ready to move on?
We are ready to move on. Why don't we have a little fun first? Let's give some stuff away. So Michael, we have 3 giveaways going on in this hour. The first 2 will be to anyone who participated. That is, you drew 1 or more of the 4 contours. And we'll do true drawings that are from that pool. And then the third drawing will be from the pool of people who are here today live. So Michael, why don't you take it away?
Alrighty. So I have the 2 gift card winners here among our participants who contoured. So the winners are Sadanad Sharosh Gandhi and Mihał Kostranowski. Congratulations to both of you. These are Amazon gift cards. They will be sent to you within a few business days. So check your email.
Excellent. Amazon gift cards just in time for the holidays.
True.
Buy yourself a scented candle or a bag of coffee or something. All righty. I think the CTV is a natural place to go next. Does anyone disagree? So we shall go here. Here we go. Here's the CTV. Now you start to see more variation. And what we have here is the cloud. And let me turn the two panelists structures off. That's the GTV. Let's turn on their 2 CTVs. Does anyone, before we do that, do you want to respond to this variation?
Not surprised. I think that the main kind of takeaway teaching point is going to actually be addressing some of this variation. It has to do with whether the CTV volume is isotropic or if it's kind of supinf weighted the way that you might expect in this kind of a sarcoma, the kind of the classic teaching for sarcoma, in other words.
So what two strategies did the two of you use when you contoured your CTV? Because we've now established that your GTVs were quite similar. What were the two strategies you used before I pop your contours on the screen?
I did I believe it was a 3 centimeter superior inferior, and then I did a 1.5 centimeter radial, but then I did obviously keep it within the skin, and then I shaved it a little bit outside of the muscle. As you'll see, there is a little bit of a muscle bite, but not as large.
Yeah, and I use a similar strategy normally, but in this case, I actually did 3 cm all around because it's a superficial tumor, which is kind of I think we can talk about it more. It's kind of the classic teaching, although I don't know that there's like evidence about this to really like kind of describe what is the best way or the right way. But we can kind of talk about, why I use that strategy that's different than some of the participants. I think you can see by the cloud, right? Because there's quite a few people that had it kind of going supinf longer.
Yep. So let's take a look at and those are great descriptions. Thank you for those, as clear as day, even to a dummy like me. So we should expect one to be greater than another, and that's what we see. We can probably guess who was who from this based on that great description.
So we're very similar sup and inf, I think, which is what you'd expect, right?
That's right.
Mm-hmm.
Yeah.
Yep. That's your 3 centimeters. And then, Shauna, you were more conservative than in the axial.
Yes.
So, yeah, I mean, I couldn't speak to this. I don't know like what the right answer is, but I was sort of always taught that it's about potential spread of tumor, right? And this is, I think, based on these old studies where they would biopsy kind of away from gross tumor volume and kind of, see how far things go. And my understanding is those pathologic studies are really more for intramuscular sarcomas, where they tend to be more limited by the fascia. The kind of classic teaching is they don't cross fascial planes, right? So generally, when you're constructing volumes, you limit your expansions to a fascial plane. Well, there's a kind of a caveat there, but in this case, there's not a fascial plane to limit it, right? So if it's sitting out in the superficial fat, it basically can travel in any direction equally. So that's kind of for me why I did this is one of the few cases, I'll often create my CTVs like manually, but this is one of the few cases where I actually would expand off the GTV kind of isometrically, or isotropically, sorry, and then would actually shave off kind of, which we'll talk about in a minute, but that's kind of how I would create mine there.
What I'm doing here on the screen is I'm trying to show, okay, what was the max extents we saw over everyone? We do see there was some wackiness here. I don't know if this was a mistake, so I'm going to change that that means one person drew something very large. Let's make it so that there had to be 2 people, and we start to see the differences in, and probably I use the word conservative wrong. Conservative, I think, maybe drawing the CTV larger in terms of you don't know where things are, so you draw larger. And then there's maybe the more aggressive contouring. Does the MR at all tell you anything about the CTV? I'm not picking up that it does at all.
Yeah, for me, I use the MR just to sort of guide that, again, this tumor radiographically doesn't seem drastically different than what meets the CT. There's a little bit of signal change, but nothing as significant as you may see in some of our other sort of soft tissue sarcomas. So that for me was a little bit more reassuring as far as being tighter. But again, I fully respect where Matt's coming from with this. And my thing when I was, as an MPNST, one of the things is you're not always going to be able to identify, but potentially what nerve is this involving, and can that be tracked in any way, shape, or form? And as hard as I looked on this MRI, I couldn't quite, justify a way that I would, methodically track a nerve sort of thing in an effort to. But so that was one thing when I looked through the MR that I tried to take into consideration, but ultimately really didn't change much for me.
Do you want to comment? It looks like there's a strategy towards the skin that was different as well. Matt, you kind of carved it in. It looks like maybe a 0.5 to 1 centimeter inside the skin. and Shauna went all the way out. What's the standard of practice there, or what helps you make that decision?
So I can speak to my practice. So basically, I do work pretty hard to dose reduce the skin. So I think if you go to the CT, it's probably a better view, because I think that there's such a huge change in deformation. So if you look at the planning scan, so essentially what I'll generally do is I will subtract off the skin anywhere between 2 to 5 millimeters, and this is for cases where there's not clinical involvement of the skin. So they show up, the skin looks normal over the tumor. It might be pushed out a little bit by the mass, but it's not like, black and blue or indurated or like, has tumor pushing through it. So assuming that the skin is not involved, I'll actually shave off of it. And you can see that my CTV is actually clipping a little bit the superficial part of the tumor. And I would admit that people get uncomfortable with that. But there's a couple of reasons. One is that, in my opinion, the skin's not really at risk, right? So I've to this date, I've never seen somebody fail in the skin. It's also resected in these patients almost always. So they will take out the skin that's kind of overlaying the tumor and either close it with a flap or do primary closure. But so in that case, it's really not at risk. The other thing is that it doesn't get zero gray. It's really just a method of kind of making sure that it doesn't get prescription dose, which I think if it gets a little bit hotter than prescription dose, in this case, we're actually at the 5 fraction kind of skim limit, at least for our institution. So that's something that we wouldn't be comfortable kind of treating in that case. The PTV, I typically will clip it as well. I guess one comment though is my guess is that if you don't do that and your PTV is right at the skin, or if it's outside the skin, my guess is your planner is probably making an op structure in order to meet goals, because otherwise you can't deliver dose to air, right? So basically you have to make an op structure anyway. So it's kind of like you could just do a regular PTV and then just like look at your PTV opt at the time of plan evaluation versus like actually shaving it off the way that I do. I literally just do a subtraction off the body contour. I don't like do this myself. So that's kind of the way that I'll do it. Yeah.
Yeah, your optimizer with trying to pump dose here in the buildup region would either be pumping a lot of tangential dose and giving you potentially really hot spots there, or the planner would put a bolus on, or you would probably most likely make an op structure so you're not driving your optimizer crazy and you'd live with what would look like a cold spot here. Is that a good summary?
Yeah, and I guess since you brought it up, it's worth mentioning that there actually is, sarcoma is an area where so one important point is like, Shauna's volume and the differences between our volume, I don't think there's really evidence to support one versus the other as being right. I mean, I think that it is what it is. And the kind of teaching point that you do superficial sarcomas kind of more isotropically is just like something I've heard from people. I don't know of any evidence for that. With the skin, there actually is a little bit of a difference there. So there is a phase 2 study out of Canada where they were able to specifically optimize on bringing dose down on the skin. They did it in a very complicated way that I don't do. They did it like together with surgeon, and they planned these like virtual flaps and all this kind of stuff. But if you do that, although it wasn't significant, it did reduce wound healing complications. And I think underdosing the skin is good in that case. It probably also psychologically makes your surgeons a little more comfortable because the skin's not super red and inflamed when they get there for surgery. The other just point that I would make is that I actually never use bolus for patients, despite the fact that it's been come up a few times with partners that cover cases and they wonder why I don't. The modern prospective trials that are open right now through NRG, at least, they actually prohibit bolus with IMRT use. And I think it's just because if you're optimizing, trying to get coverage for a superficial tumor and you put bolus on, the skin just gets so incredibly hot that it's just not, you're probably adding a lot of toxicity without benefit there. So.
Great discussion. Shauna, how would you handle like the review of a plan if you had a target, CTV target that went all the way out to the skin? How would you navigate that when it came time to look at the DVHs?
Yeah, so whenever I send contours back to dosimetry and they look, the first question you get if you don't tell them outright is, do you want bolus? And I would say no bolus for this. And I would say bring the PTV 3 millimeters like in from the skin surface. And I would do a PTV eval, just like Matt said. And then, if an understanding that my CTV may look, I would do a CTV eval probably as well. Like I looked at a case today and the PTV eval was fine, but the CTV, even though it approached the surface, was fine. So it's interesting depending how you do that. But I do look at the eval structures rather than applying bolus.
Great description. One thing, we'll go and look at the DVH sensitivity. One of the things I forgot is this is now in the results library that anybody, whether they participated or not, they can go and look and navigate and do everything I'm doing. The histograms of the volumes I put over here, 4 images. So I have images of those, but we can look at them in real time here because I'm looking at this collection analysis. And if I look at the histogram of the GTV, which I forgot to show you before, even though it was on the screen, it looked very uniform. There is, it ranged from 11 cubic centimeters to 28.27. So when we looked at the ratio of 25% agreement to 75% of agreement, it was the ratio of this line to this line. So the midder quartiles are pretty together, but the range is quite large. And that's why when you see that 10 divided by 9 ratio, it got to be a pretty big number. That's the GTV. So now let's look at that for the CTV. And here we see quite a larger range from 47 to 800. So some of these are all obviously outliers, but this hump here is much more variable. So let's take a look at how that might manifest in the DVHs. Let's get a reminder, or let's get our bearings straight about what this sample plan. I think this sample plan is a larger volume, so it's covering kind of Matt's thing. So it's a good conservative wide coverage. How would that manifest in a DVH if we looked at everyone's DVHs on top of it? Well, that's this magical. Here we go. This was the GTV. Now we're starting to see something, and what you're seeing intuitively here are, this is what I see at least. Most of the people were inside of the optimization structure for that sample plan, but those who went outside, you see the DVH start to shrink rapidly, obviously. So does that make sense? Is there any commentary on this in terms of a DVH sensitivity analysis?
Wait, so what's the blue, like, so one of the people obviously would have very significant under coverage. Is that correct? Is that how I'm?
Yeah, let me explain this a little better because I'm sure I did it terrible or no job at all. This is what's called, so this blue line, it's not one person's DVH. What it is a statistical rendering over, in this case, 59 DVHs. This represents for every dose level, what's the minimum volume of that fixed dose, but then the variable contours. So this means the min, this is the first quadrant. So 25% of the population fell in this blue region. And then we have the next quadrant, that's 25. The white line is the median, population median. And then you get to the 75 percentile. One thing this tells you is above the median, you start to see very small differences because you barely see a change in the DVH. But you really see it blow up when you get the opinion of a CTV that obviously goes outside of even what your opinion or this particular treatment plan was. So it's an imperfect sensitivity analysis, but it's a little more than we were able to do last time. Another interesting thing to look at would be, what if this had been a very aggressive or small margin plan? Then we would have seen a lot more people showing that what they would think that would be a cold DVH, obviously.
Yeah, that's kind of interesting. I think it's a unique thing about sarcoma, right? It's like, I think a lot of our types of diseases that we treat, the GTV to CTV to PTV kind of expansion is generally smaller than sarcoma. I mean, I don't know if that's true for every disease site, but like, you think about like the new head and neck contours, right? Or like just they're super tight. Whereas sarcoma, I think it's not. And it's actually been like a slow march, like over decades, from like radiating someone's entire leg, which is kind of like what they did back in the 90s. Like if you look at the old fields, I mean, it wasn't the entire leg, but it was like APPA, like through most of the leg. And then if you look kind of at C3RO, which is kind of the RTOG trial that really, set the idea that it was safe to do smaller contours, even than the Canadian study that everyone kind of knows, the randomized trial. And there's evidence, I think, that if you look at there's a German study where they tried to do this with Tomo with even tighter margins, and their failure rate was actually probably higher than we're comfortable with for local control for sarcoma. So it's interesting because I feel like that 3cm, however you're expanding it, is probably, in my opinion, probably the floor of how small we can get things safely, mainly because it's really hard to set these up, right? If you look at the same study, the same RTOG 0630, there was actually a correlative study of just setup error, and they're huge compared to other types of cancer. I think extremities are just kind of like how it's really hard to fuse them for the same reason. It's really hard to set them up because there's just so many degrees of freedom, and these patients can be challenging to set up sometimes. So it's funny because it's really a balance between having tight margins and tight contours to preserve function in the long term, which is one of the biggest reasons we're doing this instead of just doing an amputation, versus recognizing that it's challenging to set up. So you could easily make a 5 or 6 centimeter contour or target, and you would have no concerns about setting that person up, but you're going to, cause them a lot more toxicity. So it's kind of like an interesting, it's part of why I think sarcoma is the best site, because it's the most interesting site to kind of set up like that, I think.
And Matt, as we're looking at these numbers and talking, the problem in part is that we know that sort of volume of tissue matters, but in reality, you don't actually have an OAR here to like measure that. So like when you say, oh, like all we're looking at is tumor coverage, but that's because we don't have an adjacent OAR, even though I think, and what I'm hearing is like, we kind of, although muscles are like somewhat forgiving, I don't know, can you kind of speak to that? Like in terms of when you think about, because obviously you're radiating like a larger volume compared to a smaller volume, you do expect, but we just don't have any sort of dose constraints. Like how do you deal with that?
Yeah, that's a good question.
Or even guidance. I think that's where you will take us with the skin strip, is like you're trying to create something to help you create an optimal plan, but there's not a whole lot of guidance,
Yeah.
OARs for that, but
yeah, I don't know. I mean, Shauna, feel free to jump in. This is really, I would actually argue that this is probably where I struggle with teaching sarcoma the most, because we'll talk about the skin strip, I guess, but that's more of like a guardrail against you radiating their entire leg, which you shouldn't do. And that's the most toxic thing. But you are right that there's probably some middle ground between a correct volume and too big, but not the entire leg. And then you're still kind of making it toxic. I don't know the right answer to that question. I think, I really look for conformality, to be honest. So like when I review these plans, I will often turn on, I guess there's a lot of like kind of to unpack with this particular plan. But if we're doing kind of the old, long course, like the 25 fractions to 50 gray, I'll often turn on the 20 gray volume and look at that just visually. I'll just kind of scroll through and look at the 20 gray volume to kind of get a sense for how much of the leg is getting kind of what, in my opinion, is a meaningful therapeutic dose that could cause toxicity. And I really am asking for conformality. That's really the way that I would do it. You are right. There's no metric.
Yeah, and the tough part, especially with this case, so with each case, I always look at, what are our OARs that are, directly abutting or in the immediate area to prioritize. And like, your skin strip's interesting for this case, but it's a pretty small target on a fairly reasonably sized leg. And then the bone's not that close, so you don't really need to worry about the bone. So to me, it comes down to, more of those wound healing complications and how much skin am I radiating. And, one of the things I've enjoyed is going into the OR with the surgeons for brachy, because I get to see how they're cutting, where they're cutting. And then I always try and keep that in mind when I'm looking at an MRI. And it's like, all right, so what is the surgeon going to do? What sort of ellipse are they going to take? And where is it important where my dose is? So that's something that I found useful. And again, there's no perfect answer for this, but what are you going to prioritize and sort of go through that list, just like we did when we talked about the agreement between structures.
Well, actually, I love your analogy because at its best case limit of perfect delivery, perfect gradients, when you're drawing the targets, you are doing surgery. That's where if you could make it hit. So it becomes your decision. without being able to see inside the body. And just kind of to close out the CTV, there's the one thing that's probably worth noting is we heard two different strategies there. If one thing I can say here is if we look at Shauna and the population, I think there is uncanny agreement between like the 50% consensus, almost to the T, following the logical rules that she went through. And then there was Matt's opinion on, well, if I can irradiate more without hurting the leg, why wouldn't I? I hate to simplify it that way, but that's kind of what maybe the summary. And one question I might have is, how do we choose between these two paths? Is there a study of leg function that has to be done to say how much can we irradiate of the fat and surrounding muscle before we start to see a degradation? And then also, are we studying local control? I mean, how do we drive towards a consensus where here the consensus was not about locating anything? It was about where you want to put the dose, where you want to do surgery. Do you have any ideas, just as an industry, in an ideal world, how we could drive to making data-driven decisions?
Well, the data-driven decision is the very tough part of that. One thing I will say about the case that you gave us here is it's a fairly small target. So I would be very comfortable with what Matt drew and knowing that I can safely radiate that volume. It's okay to be more generous on that, in that radial direction. You can do that. That is. Now, if you were to give Matt like a really huge tumor and going more radial would result in more circumferential, I don't know if that would, change your thinking at all, but probably be a higher risk tumor then as well. So.
No, I think it's actually a good point. I think that so the guidelines that we all know for constructing the CTV, which is actually, I think, has been like kind of codified in the recent Astro guidelines, which are really nice. It's like the first sarcoma guidelines. So there's definitely some good guidance out there. But this is genuinely a place where we do this based on like personal experience, which is not what we like in oncology, but sarcoma is incredibly rare. And the chances that we'll get, I would argue the chances that we even get a 2-arm trial of any kind in radiation and sarcoma is probably, 0 in the near future. But certainly being able to like compare small differences in contour or target strategy to kind of relate that to physical function or control is probably challenging as well. Mainly because these days people have pretty good physical function in the long term, and we have excellent local control kind of across studies, like higher than 90%. So you need a very, very large trial to kind of tell the difference between the two. I think that with this, just to kind of speak directly to your question, so I think if we were to have a much larger tumor, something that I'll often do is I might actually cheat, because I think you have to balance for the patient the added local control benefit of covering more area versus the toxicity from it. And then the thing that we haven't really talked about is that every patient for sarcoma does have a competing risk of metastatic disease that's going to be higher than local recurrence. For most people that you're radiating, it's going to be far higher. So I think that that's something that I tend to keep in mind. And actually for this patient, which I think we put in the case was an MPNST, that actually might be a case where it's actually like kind of maxed out, where the distant metastatic risk is incredibly high. And normally you would not worry as much about local control, although you have to balance with the fact that MPNST histology is an independent risk factor for recurrence. So it's sort of like a challenge in this particular case. That probably did not really answer your question, I think.
It's all been a great discussion. So actually, I want to take this as go ahead, Erin.
Oh yeah, no, I just wanted to, on the topic of CTVs, there's a question from the audience about when do you decide to include a compartment or even an adjacent compartment if there were invasion there. I mean, I think you could see some of the variability was happening because people couldn't decide which compartments to maybe include.
Yeah, so I actually want to hear what Sean has to say, but I just want to quickly make one comment about, so I follow the standard kind of guidelines when it's within a compartment of a muscle. I will have an anisotropic contour where it's taller than it is wide. I use the 1.5 and then 3 cm for high grade supinnymph. And I tend to not go beyond that unless, I really don't go beyond that. So I never really like kind of blanket include a whole compartment. I do take a muscle bite. I know that like on the eContour website, the contours are very tightly constrained to the compartments. You'll see on my volume, and I think on Shauna's as well, there's actually technically the muscle deep to the superficial area is not the same compartment, but both of us did take a bite of that muscle. For me, it's a safety margin. It's just when things are just so tight, and knowing that these are hard to set up day to day. And especially because this was a 5 fraction plan, I do add just kind of like a subjective safety margin there to make sure that we're not so tight at the muscle. Also in this case, both in the MRI and here, it's just like, it's a little fuzzy right there. And typically they won't invade into a compartment, but I don't know. I just, I kind of take a bite there, I think, just to be more safe.
Well, and it looks like the population agreed with that bite strategy as well, as you can see here.
Yeah. So I was just going to say, with respect to the compartments, it's very challenging as radiation oncologists. We don't know the anatomy as well as the surgeons. Like, they can tell you exactly what the name of every muscle there, and I'll admit I'm still looking at trying to figure out what every muscle is in the compartment. I fully admit to that. And so again, I tend not to go, I think the question isn't always so much as expanding it within the compartment, but more so where is it safe to shave it? And that can be challenging. So again, it's just using all your anatomy, your atlases, and if you've got at your tumor board discussion, like I'm always trying to think about those things when you're talking about the case at tumor board, when you've got the radiologist there, and it's, where are the boundaries of that compartment? I think that's a really high yield time to sort of parse out some of those details for your, when you're thinking about drawing these structures. So if there is a clear delineation and it's within the compartment, I do carve it outside of the, I carve it outside of the adjacent compartments. But again, the thing with these is always, I don't get too fancy. Like, there's more variation in these than your head and neck patients that are in, a 5-point mask. So just sort of always respecting that variability that you can't anticipate. And then you feel better when you're looking at your cone beam every day, that there's a little bit of wiggle room in there. I know the principles are your PTV is your, setup error, but we're still thinking about that with our CTV.
Yeah, you're sparing the muscle that you bit into a little more than you think you are because of that variation.
Mm-hmm.
Well, maybe the AI engine someday will not only delineate what we're used to delineating, but they'll fully delineate the musculature of the human and label them for us so we don't have to remember our anatomy books. And then they can predict how much we can lose before we lose function. That's the brave new world we're heading towards. Let's jump forward. Do you want to now, by the way, I was just going to say earlier, this is awesome. Thanks for the two of you. This is really good. I hope you're enjoying yourselves.
Yeah.
Do we want to jump next into the genitalia or the skin strip? I think they're different conversations. What are we ready to do next?
I would say in the interest of time, we should do the genitalia. We can probably just explain. I mean, the skin strip is just an avoidance structure. I actually don't use it in a lot of patients because I've now do so many of these with my dosimetrists that they just know not to radiate axially the entire leg. So I often don't need to put it in, but that's kind of, just to be clear, it's basically just I don't know if you want to like show it real quick, but it's just like an avoidance. Like, you literally just put like a circle, and typically on the opposite side of the leg axially, just to again, it does have a dose constraint in a lot of protocols, and you want to just do it to have your dosimetrist kind of avoid giving circumferential radiation around the extremity, which just as a rule is like a really bad thing to do in any setting. So just like, when you're practicing, like, don't radiate a circumferential leg.
So there was a good amount of variation here from the population. Some just thought it was a skin, like bringing in 5 millimeters from the surface. So let's just focus on the, and it looks like only one of the two of you did this one. No,
because mine's the more medial one.
Oh, well, are these actually, oh, it's not bifurcated. Okay, wow.
Yeah,
All right, let's
they're
talk about this.
different.
Let's
Yeah.
talk.
No, I mean, those are both reasonable to me. I mean, it's just basically you want dose away from your tumor. Yours probably makes more sense because it's medial, and that would be a place where I wouldn't want to radiate. So I guess yours is better. I actually like yours more than I like mine.
No, I try and think of like where the beam is going, like, because you want to, if you're doing partial arcs with this, you want to try and work with your dosimetrist as far as, sparing a structure that I'm probably going to maybe spare because it's coming from the other side. Again, some people's might be bigger or smaller. I just, again, use it as an avoidance structure. So it's just like giving your dose, the number and the like dose to that structure means a little bit less to me. I like Matt turn on some low dose isodose lines to take a look at those and see where they fall as the more guiding structure than the pure dose to the skin strip. But if you get into a situation where you've got a big target, circumferential and limited uninvolved, then it's, I think, very useful.
Let's take a look at how that manifests in the sample plan then. So this, Matt, is this your plan we're looking at here or close to it? Probably.
I think so. Yeah.
Yeah.
It seems like it probably is.
So
Yeah.
here you can see how that manifests itself in the dose distribution. I can kind of turn it on and you can see
Oh yeah. Mhm.
see that hole there.
So it doesn't look like it impacted the planning even really that much, right? Because it's
Well, they're so good too, right? They're so conformal these days, and with that target too, it's
But it is important. It sounds like that both of you have a similar approach, although it's just showing it doesn't matter so much where you put it, but to consider avoiding an area so that it's not in a larger tumor. It might be more relevant for a.
Yeah, and there are definitely times they optimize on it. I mean, I would just the constraint that I use for it is V20 gray less than 50%, which in this case is So that actually is the constraint for longer course. I can't remember or don't know if there's yet a constraint for shorter course. But you can see how if it was a very large tumor that took up 75% of the axial leg, it would actually be challenging to meet that. So you'd have to kind of optimize on it. But in this case, it really was like not a concern.
Great discussion. All right, well, while I'm jumping into our last structure that we can discuss, let's give some more stuff away. Michael, take it away out to the attendees in today's meeting. Somebody gets an Amazon card. Who is it?
Absolutely. So congratulations to Juan Carlos Parisalas. You will receive your gift card within a few business days. Thank you for attending.
Very good. All right, without further ado, our last structure. And what I'm showing here is, when you look at the picture, it seems to be a lot more consensus than the metrics led on. But it does say that some of the population drew very small and some less small. So the factor of volume gets quite large. And we're actually seeing that manifest with our two panelists. So let's talk about this a little bit.
Yeah, mine are the larger structures. Again, if I'm contouring a structure like the brainstem and the optic nerves and the chiasm because I've got, a skull-based tumor, then I'm very tight, very specific. When it comes to more of an avoidance structure, and especially with this case, the target wasn't really near it at all, but I think it's a good thing to talk about, especially if it's a more proximal thigh. I tend to draw when they're avoidance structures a little bit more generously because I want sometimes the dosimetrist will only push on what you give them. So if you're tight, that your lines will come up right close to that, if your target was closer than that. So I tend to be a little bit more broad, vagina, rectum, because I think the dose to all of those things it matters, but your dose to your vagina and your vulva is going to be the highest.
Yeah. So do you include the internal anatomy? Because I actually never knew what the right answer is there, right? When people talk about genitalia, I guess they mean external, right? But it looks like both of us kind of included the vagina. I don't know. I actually don't. Yeah.
It's just this is not your target. I want you to I want my planner to avoid this whole area sort of thing is more of my avoidance. Now, if I'm drawing like a cervix case or something like that, obviously my contours are a little bit different, but you know,
So
if
does
I'm
that-
drawing an extremity sarcoma, then it's a
Does
little
that
bit.
manifest itself in your objectives then? Because you're almost doing more conformal avoidance of keep dose out of this region. So you might be looking at different DVH or mean dose or max dose goals than if you were looking at an organ-based side effect, right?
Exactly. And I think that's the most important part when you draw these structures is understanding how that changes your dose. And, you know, when I draw a larger structure like this, the mean dose, you know, is probably going to be lower than if I had drawn a smaller structure. So I think that's the important thing when you're, you know, putting all the pieces together, when you're evaluating the plan, to know that I drew this bigger, and you want to make sure you're not artificially driving down the mean dose.
This may be the perfect case to show. So we saw very large DVH sensitivity for the CTV structure, and that's because that's where the gradient is. Here we have a distant structure where we saw more variation than the PTV. Well, let's take a look at how the population DVH changes. Just to get our bearings, we did have a pretty good range of the volumes of the genitalia, ranging from, this is about 11 cubic centimeters. This looks like an outlier, but it's large, maybe more conservative, more conformal avoidance. But we see, you know, at more than a tenfold difference in the opinion of the volume. Well, how does that manifest with the DVH? Let's take a look. So that's interesting. You see the variation actually starts to be controlled more. That's just because it's in a lower dose region. So this would be one of those structures. In this case, it's less sensitive to contouring differences. I mean, kind of stating the obvious, but it's good to see that the imagery bear that out.
Yeah, and just to like, I guess, echo what Shauna said, I think that it's more of like an avoidance structure, and we're not, unless you're, I mean, even in the anterior, like proximal thigh, you're not really talking about doses to these structures that are going to cause them long-term substantial toxicity. It's really the difference between someone who's pretty mad at you because they might have irritated skin in that area or mucosa that does heal versus not. In this case, you can see that it like doesn't, you know, I mean, 0.25 gray is like,
yeah, the x-axis is like a little bit of look at it's all sub 1 gray.
Yeah, and this
so
is
if
far away.
If we were to put this on the same scale as the target volume, this would almost look like a line.
But it might become more important in a place that doesn't, like, we do planar or not, you know, if you do non-planar arcs or plans where you're shooting kind of super inf a little bit, that would be something where it's a little bit more of a concern. In this case, it's far enough away that it's, you know, above where we're treating. So
yeah, and this brings up actually, I think, a really good point to talk about. Again, not totally applicable to this case because it's a little bit more distal, but when you get a more proximal lower extremity lesion, especially if you've got it in like a young woman, we all know the ovaries are very sensitive. So you don't want to put them in early menopause. Like, it's, you know, your single digit dosing is what matters. So always making sure you're scanning enough so that you can draw them and get the ovaries within your dose grid. And just looking at that, because again, that's low dose that matters, and your planner's not going to intuitively think of that. So I think as a physician, that's an important point that you don't always think about if it's a thigh mass.
yeah, and they might have chemo too that might affect their fertility. So it's like adding, you know, even more important, I think, to preserve them or to spare them.
Yeah, I guess just to state the obvious for anyone who might over the months or years will stumble across these videos and not be a radiation oncologist. The radiation oncologists really are. They're not only drawing things that they want to surgically with photons or electrons or protons or remove, but they are surgically outlining regions that they want to spare. So it's those of you budding physicians out there, radiation oncology is extremely exciting, especially if you're a little bit of a geek and you like technology. You know, a little recruitment for the radiation oncologists of the future. I see we're coming up on our hour, but I think we're having fun. So I'd say, Erin, are there any questions to triage, or are there more topics you want to discuss?
No, maybe like a final question. I think you guys have both commented on this, but any pearls for people, how you're treating MPNSTs different than more run-of-the-mill sarcomas in, say, this location?
Do you want to go first, Shauna? I don't know.
No, go ahead. Go ahead.
Okay. So we are, I guess, lucky here that we have a one of the country's NF1 experts as part of our medical oncology team. So we see a pretty high volume of MPNST compared to a lot of institutions. With me, it is, so one thing that I guess it's hard to say just in a couple of minutes, but there is literature support for excluding radiation or deferring radiation in patients like this that have small, superficial, high-grade sarcomas. There's prospective data that argues you could just not radiate safely. I do not think that's the case for MPNST. It is a long known independent risk factor for that. Histology is an independent risk factor for local recurrence. So it's something where I would not just let this go. We're also generally maximally aggressive with these patients because the outcomes are pretty poor compared to other types of sarcoma. So almost everybody gets chemotherapy as long as they can tolerate it, and then we do radiation and then surgery. This particular patient, I used the short course regimen because they're from very far away. So that was actually the main driver for the short course. And that's frankly I know as institutions move towards that, there's, multiple reasons to do it. But for me, one of the biggest ones has been distance traveled for the patient. But you could actually argue that you probably want to minimize their time spent on local control, because no question for these patients, distant recurrence is the biggest concern by far. So for us, it was like we could get this patient in, do the radiation and surgery within like 2 weeks, and then they're on to chemotherapy as quickly as possible. You could flip it the other way if you wanted to and do chemo first, and a lot of places do that. But I think in this case, the patient was pretty symptomatic, so we started, I think, with the local treatment.
Yeah,
I think
so
a lot of knowledge was dropped. Shano.
at our institution, again, we're similar to Matt in the sense that we do adopt quite a bit of hypofractionation. So 30 gray and 5 fractions is something that we do fairly often here. We tend to stick with standard fractionation for tumors that we're looking for a little bit more downstaging potentially. The 30 and 5 is nice because they get it out about a week later. We do surgery, the next week. So the whole treatment time, if you're not doing chemo, is very condensed and decreases the impact on day-to-day living, and people get back. Another thing that we do at Cleveland Clinic a little bit that not everywhere does is we do quite a bit of brachytherapy. That's something I enjoy doing. This would be something that you could consider. Oftentimes when we're doing brachy, there's overlap with what I do 30 and 5, what I do brachy. So we have a lot of different options for these patients, but this is definitely something you could do brachy on. With brachy, we do tend to favor putting delayed closure. So we resect, put the catheters in, put a wound vac on, and then we can start post-op radiation on day 0, day 1. If you do primary closure, then you're looking at more day 5. So that would probably be a big deciding factor for me. Like this patient, if the surgeon was going to close them primarily, which I would probably expect, then I would probably favor doing the 30 and 5 pre-op as well.
That's pretty interesting. We could probably just also say to people that there's a really nice consensus document from Brachytherapy Society about that. Do you do 5-day BID for radiotherapy? Is that what you do?
Yeah, we do. We usually do between 36 to 38.5 and 10 fractions BID over 5 days. It can be challenging to get in. It requires a lot of coordination. First case in the OR, on Monday to try and get all of those fractions. And occasionally you end up with a TID day as well. Trying to account for that, or if you do 9 fractions to sort of work with that. So yeah, that's what we're doing. So it was a big year for guidelines. We have the external beam sarcoma guideline and then the ABS brachytherapy guideline. So we're all up to date on that, and plus the do-re-mi stress. So we've got there's a lot of exciting stuff in sarcoma this year. So it was a good year.
Yeah.
Great. We'll be sure to include links to those as well when we post. So Yeah, I think we'll probably wrap it up then, and thank everybody for your time today and the questions from the audience, and any final thoughts from any Diana or Mike?
I would just like to say that the implications of what we're doing here has profound consequences. We have the potential as a group to change the standard of care in radiation oncology. So thank you to everyone who participated and everyone who called in.
Yeah, thanks so much for being here. We really appreciate it.
And I thank you for the enthusiasm of our two panelists. I think we found a sweet spot with two panelists is really good when we have an hour. And I think also trying not to go too much beyond maybe 4 structures. So with that in mind, the next 2 exercises we're going to do, C3RO, it's actually going to be a single head and neck data set, but we're going to focus 1 discussion and results session on the targets, and then 1 on the organs at risk, because we don't want to rush through that, through anything. Like, I think we learned a lot today just covering 4 structures. So that's the next plan, head and neck. We will get a lot of participation there. Everyone does it on the daily basis. But thanks again. Thanks for paying attention to C3RO, and don't hesitate to give us more feedback on how we can improve this in the future. We're just getting started and we need you. So everyone have a great day, and we'll talk to you next time.